Good morning. All right, so let's get started. So this week, what we're looking at is the issue of stroke. And Kira's here today. She's already been through this particular course, and she's been through advanced cardiology. So again, anything that you need to add or put in, Kira, feel free to just kind of jump on it in there. Basically, strokes are the same etiology or the same basis as what happens in the heart. We've been talking for the last couple of weeks about myocardial infarctions, how you get a blockage in the heart, no blood flows beyond the heart, and tissue begins to die. Or you get a partial blockage within the heart, and your patient begins to have angina that can either ease off by rest or by the use of nitroglycerin. Something very similar to both of those situations occurs within the brain itself, as well as a third type of situation of when an artery within the brain ruptures. And we'll talk about all of those here in just a minute. But basically what we're looking at here, when we're talking about the brain is what makes us who we are. Scientists understand much more about the brain now than we ever have, but they've only scratched the surface. And literally when people are looking and studying the brain, the more you learn that the less that you know about the brain itself. It used to be said that, we only use about 10% of our brain. Well, that's been pretty well debunked. We use all of our brain. It's just in certain situations, we're able to use it more efficiently. When you're rested, when you are hydrated, when you have good nutritious food, when your stress levels are not over the top, your brain functions really pretty well. But if you adjust one or more of those in a negative manner, you're too tired, you stay up all night and you study or you party, you put things into your body that are not good for the brain, such as high-fat foods, such as narcotics, such as overuse of alcohol, then the brain begins to not function nearly as well. A key thing to remember is that when our brain cells die off, they do not regenerate. So when you and I were born, we had all the brain cells that we were ever going to have in our entire life. Those cells began to enlarge and change structure, but now, but when you're born, you have all of them that you're going to have. Unlike, say, like your arms or your legs, now we have more cells in the muscles of our arms and legs, in the bones of our arms and legs, as well as the other organs than what we had when we were born. The brain, on the other hand, not so much. So you're handed this incredible organ and you want to take care of it and you want to protect it as much as you can. Other thing to keep in mind is that when brain cells die off, and they do as we get older, even if you are living an incredibly healthy lifestyle, your brain cells do eventually begin to die off because of age, because of pollution, because of inflammation, because of secondhand smoke, things around us, because of trauma, because of disease. Those cells die off, and just like the heart, they do not regenerate. They don't come back. We get a cut on the arm. If it's a minor cut, it heals up. The skin covers over. It comes back. It may leave a scar. It may not leave a scar. If we take the liver, for example, we know now that you can take up to half of a person's liver and implant it into another person, and both of those livers will regenerate, not to their original size, but they will regenerate and continue to function. The brain will not do that. So again, this is one of the things that I try to stress to people is do the very best you can to protect your brain from the different things that can come into process with it. And again, like the bottom bullet says, is that the things that you and I experience, the different levels and the different types of education, even the different instructors that you interact with, your social environment, whether you have a strong family environment or not, whether you have lots of friends or not, all of those shape the brain, and the brain shapes and makes us who we are. Okay? Now, here's the thing to keep in mind you actually have two brains. You have a left brain and you have a right brain. All right? A key thing to remember is that this side of your brain, your left side, controls everything over here on the right side, and vice versa. This is important to remember, especially when we're assessing our stroke patients. So, if we have one sided weakness or one sided paralysis, we can begin to recognize that most likely the damage that's occurring is coming from the opposite side of the brain. Now, when we're looking at this, it used to be thought that you had a left brain being logical and right brain being. Go ahead.
Do we know why it switched?
We do, because basically what happens, it's interesting the way the brain is created is that now we don't know why. But all the wiring that comes in from this side of the brain actually goes down the brain stem and goes to this side of the body. So we understand the wiring of the how, but exactly why it does that, I've never seen anybody be able to explain it. And so the same thing happens over on this side. If we were to cut the brain down this way, all the wiring, all the nervous pathways, again, lead down into the brainstem, down into the spinal cord, and now come over onto this side. So it crosses over. And very similar things happen within our sight as well. Good question. So it used to be, and I don't even remember if I get this right or not. You'll never see it on an exam. It used to be, you're right-sided, you're right-brained or your left brain. Left brain was logical, right brain was basically very creative. And that's been proven as a fallacy as well. We use both sides of our brain to be able to make the good decisions as well as to be creative and do things along with that. Now, we do understand that our decision making comes about from the front of the brain called the prefrontal cortex. The prefrontal cortex. And when a person has some type of a damage, either from disease, such as we could see from brain damage from a stroke or from trauma, when that part of the brain is damaged, they no longer make good decisions. A number of years ago, and I'm just sharing the information with you, it's not a slam against one gender or the other, but it was determined that males typically do not have the prefrontal cortex that is fully developed until the early to mid 20s. Gentlemen, that's why women have a tendency to live longer than we do as men, because they start making better decisions at an earlier age, not because of their gender, just because their brain develops quicker than ours does. And so we still have a tendency let's admit it, we all have a tendency to make good decisions and bad decisions regardless of the age. But we take more chances, especially if we are male and we're in our 20s. Again, not because of our gender, but because this organ right up here has not yet fully developed that allows us to make good, rational decisions. It develops a little bit quicker in females. Now, let's kind of look a little bit deeper at the brain itself as far as some of the pathophysiology. And I'm recording the lecture. So, again, you don't really have a lot of material to read from. I'm going to share some additional information with you to read, but most all of the questions that we will develop for our exam, for our final exam, will come from this particular lecture. So you might want to go back and look at it or listen to it a little bit later on. The left side of our brain has the area that controls speech and language. So again, this helps us to now begin to understand when your stroke patient has slurred language or slurred speech and they're not able to speak clearly, or if they're not able to speak at all, again, that helps us to be able to identify we've got something that's going over here on this side of the brain. Don't worry about Broca's area. We don't have to. You don't need to worry about that. But there is a word I do want you to be familiar with, and that's aphasia. And you see it spelled there, Aphasia. Aphasia simply means I'm not able to speak clearly or at all. I can hear what you're saying. I can process and understand what you are saying to me. But when I go back to speak to you, it either comes out in gibberish or it comes out slurred. So aphasia is definitely a word that I would really, really want you to be aware of. The left side of our brain also has to do with math. That's why the left side of my brain is only about that big right there, because I don't understand math much at all, okay? Other people who are really, really smart in mathematics, those people that are going to get doctorate in mathematics, I mean, it's kind of like their brain is huge in that regard. But again, that comes in within the development of the brain itself. Now, the right side of the brain helps with sight and hearing. Okay, sight and hearing. It also helps us to begin to make sense of the shapes that we're looking at, as well as this side of our brain helps me to be able to look at you and to recognize. So I recognize sitting back here on the back row, being really, really quiet is Naomi. So I can recognize her face and I can put a name to it. Okay. And so many times patients who have strokes will not be able to recognize someone, especially if the stroke is going to be over on the right side of the brain. Now, these are the regions of the brain, and there's only really two things that I want you to know as far as the anatomy of the brain right now for this particular class. Number one, understand that the cerebellum is the largest part of the brain, okay? And that's basically this top part right up in here. The other thing that is important for you to remember is what I addressed just a minute ago, is the prefrontal cortex and the fact that that's where we make decisions, whether they're good or bad. The more developed the prefrontal cortex, the healthier the prefrontal cortex, the better decision making that we're going to have. Okay, so number one, cerebellum is the largest part of the brain. Number two, prefrontal cortex is where we have our decision making capabilities. And then lastly, what I want us to look at is actually the brain stem. The cerebrum, not the cerebellum, but the cerebrum, but the brain stem. The brain stem controls what are known as vegetative functions. Vegetative functions are the things that we don't have to think about. Our heart rate, our blood pressure, and our breathing. Okay? It controls all of those and it tries to maintain those at all cost. All right. Now, when you get into advanced trauma, we'll actually talk about when there is trauma to the brain, what happens to the brainstem, and how can we know when that brainstem is experiencing damage coming from head trauma going on in there. Now, in order for you to be awake, and this is a Monday morning class, I understand. Okay, so our levels of being awake and alert are different, but it requires two things. Number one, it requires arousal. Okay, arousal from a medical perspective just simply means, okay, I'm awake now. All right. The other thing is cognition. Cognition means the ability to process information. Okay. If you wake up in the middle of the night suddenly, especially let's say that you're traveling and you wake up, you're staying at a hotel or you're camping or whatever, and you wake up someplace that's entirely different. It's going to take you a few moments to get your bearings, for that cognition to now begin to kick in, for you to understand this is where I am. And this is how I'm going to be able to navigate this particular room where I'm at. It also helps us with our ability to orient, to know time, place, and person. Time would be both calendar as well as actual clock time. Place is the overall place where we're at. We're at home, we're at school, as well as other things that come along in there that's really, really important to remember. What we're doing is that the arousal part requires an intact and functioning brainstem. Okay, when the brainstem is injured, this is where patients now will begin to lose consciousness, to go into what's called a persistent vegetative state, of where they're alive, but they are no longer the person that they once were. Okay, you're no longer able to interact with them. They're not able to interact with you. They don't recognize you. Basically, the only thing that is going on are the vegetative functions of digestion, of heartbeat, and respiratory status that's going on. So what I want to do with you for a few minutes is let's discuss what an altered mental status is. An altered mental status can range from being completely unresponsive to simply being anxious. Okay? And this is the danger that I stress to all my students when we're assessing patients that we suspect may be in shock. Because remember, an altered mental status of anxiety, if somebody comes in here and starts firing off a gun, all of us are going to get anxious. If you don't, there's a problem, okay? But that's a normal response. But let's say someone gets hit with a projectile from that weapon and they're awake and alert, but now they're anxious. The danger of that is that the normal response, Travis? Or is that an early indication that our patient is in compensated shock? The only way to know the difference is to do a continual and thorough assessment on your patient to either rule it in as being an early indicator of shock or to rule it out as simply being part of the sympathetic nervous system that causes us to have some that anxiety that's going on. Basically, we're looking at all of these different things that are listed up in here: altered behavior, confusion, change in higher cerebral functioning, which basically would maybe make us a little lethargic, slower to answer. Being able, changes in memory, forgetting things, especially if that change in the ability to use our ability to remember things is acute. If it's a sudden onset, now that comes into play. So the big thing to remember is that All of these things, or individually, they can indicate that your patient has an altered mental status. And again, the big thing I want you to focus in on is don't blow off someone who's anxious and immediately say, well, you just had a wreck. That's normal. Or you're just simply having an anxiety attack. That's normal in this situation, because it could be something else that would be really, really major. When we're assessing our patients, one of the most important key things that we can do, from a determination of level of consciousness, and remember, that's going to be one of the things, if you haven't already gone through your EMT course yet, you'll learn, and if you are already an EMT, you should already know that. That's one of the things that we assess first in what's called our primary assessment. Primary being first, being the most important. And so what we want to do is that we want to determine a baseline. Well, how do we do this? Well, first of all, we go and we talk to the people who know this patient the best. Many times you're unable to get answers for these particular questions from the patient themselves, because if they have an altered mental status, they're not going to be able to give you accurate information, nor is time going to mean the same thing to them as what it would normally mean to us that are not functioning within an altered mental status state. But ask your patients, okay, or ask your patient's family or the bystanders, friends or people that were just there. Some of these things would be, number one, when was this patient last acting normal? Okay, that's a critical question when we are assessing stroke patients. You'll learn why that is in just a minute, because that determination that's going to often be made by you as the paramedic can have a direct impact on which route the treatment will go for this particular patient. We'll talk in a little bit about different types of treatment modalities for stroke patients. The longer they get away from the onset of when the symptoms start, the greater the risks begin to go up. And at a certain point, the risks begin to outweigh the benefits. And as such, now what we have to do is we've got to try to determine as accurately as possible, not exact, because medicine is not an exact science, being a human, not an exact science, but we want to determine as close as we can possibly, when was the last time we saw this patient acting normal? Here's the other thing that's closely associated with that. What is normal for this particular patient? Now, again, I've had the privilege of working with all of you all throughout this semester, and some of you I've had it in other classes as well. If you came in and you began telling me that you were the Queen of England, first I think you were joking, but if you really, really projected that, automatically I would know, wait a minute, that's not normal for any of y'all in here, okay? So I could determine very, very quickly, you really do think you're the Queen of England. That's not normal for you. So those types of things are usually pretty easy to determine. But what if you've got a patient who lives in a persistent vegetative state? How do you determine what is normal for them now? I mean, in essence, what you got to do is you got to go to their family, you got to go to their caretakers and say, when they call you in and you've got a patient there that is unable to talk, unable to communicate, because they have either had a long-term history of delirium, maybe Alzheimer's, maybe some type of either an organic brain disease or some type of brain trauma. You got to find out, what is their baseline? What is their normal? And so many times they'll say, you'll ask this and they'll say, well, patient X is normally able to make some noises, but for the last 3 hours, they haven't made any noise whatsoever. That's a deviation from their baseline, okay? Your baseline is, for the most part, you're awake, alert, listening, interacting. And so if you were to suddenly become unresponsive, that would be a major change. Or if you were suddenly able to only make certain types of noises, that would be a major change for you. But with some patients that have chronic brain trauma or illnesses, we understand that now this is the baseline that we begin to measure from. Get a good history on your patients. Okay, we want to find out, do they have any allergies? Do they have any medications that may be leading into what their current state is? There's all kinds of medications that can cause a problem out there. Okay, a patient can have a type of an allergic reaction where they begin to have unresponsiveness. But remember, side effects come into play here. We know that like if we take a beta blocker, it can drop your blood pressure, it can drop your heart rate. That decreases perfusion going to the brain, and as such, now what happens is that we have an altered mental status. We know that certain types of medicines, such as narcotics, have a direct impact on the level of consciousness of your patient. So you want to find out, are they taking legal medicines, prescription medicines, or are they using recreational medications that are not legal? If they are on prescription medicines, the next thing you want to find out, are they compliant with them? Compliancy means they take them the way that they're supposed to. They don't take more than what they're supposed to, but they also don't take less. In getting your history of your patient, find out, have they been in the hospital? Do they have any type of psychiatric condition? There are certain psychiatric conditions that can cause a person to have an altered mental status, even though physically the brain is working within normal circumstances. Have they had any type of infection? Spinal meningitis is a type of disease process that can affect both the brain and the spinal column, leading into problems of altered mental status. When you go into an environment, taking and assessing your patient, take just a few seconds and take a global view of what you're walking into, whether it is a car wreck or whether it is walking into somebody's house. First thing you need to be looking for are hazards to you. I want you to go home at the end of your shift, every shift, and I want you to go home with all the parts that you showed up when you checked in for your shift that day as well. So look for things that could hurt you on accident scenes, things that could be fires, things that could be lacerations to you, things that could explode. When you're going in and dealing with people, look at things that they could use or other people could use that could hurt you as well. But the other thing, now when we're getting our history on our patient, is that look at your environment. Are there medicine bottles around? Are they open or closed? Are they full or empty? Look at the medicines and, let the patient know, let the bystanders know, hey, this is going to help me to determine what's going on with my patient. Looking at medicines that could be abused, such as narcotics, such as benzodiazepines. Do a pill count. Try to look and see, when was this filled? What is the prescription? If it was filled, 3 days ago and there's only 2 tablets left in there, it's kind of like, Houston, we may have found what our problem is here. And so determine from the environment what is going on in there. The family can be your best friends or your worst enemies. And in this situation, what you can do is the family can often look at just little teeny tiny subtle changes in the patient. This is especially true, Sydney, if the patient is in a chronically persistent vegetative state. They'll look at them and say, he's just not acting the way that he would normally. Get them to give you as much detail as to what that means when they're telling you things like that. Some of the things that you can see that would lead you to under or to suspecting some type of a brain function change, and again, this can come about from disease. It can come about from toxins, and by toxins, we're not just talking about poisonous things. We're talking about things such as narcotics, benzodiazepines, alcohol, smoke, poisonous gases, things along there, or it could come about as a result of trauma as well. So all of these things come into to play here as far as when you are assessing your patient. Your assessment skills are critically important to me. Many times when students come in, they want to get to the bells and whistles. They want to do the fun stuff. They want to they want to intubate. They want to start IVs. They want to give medicines. Well, we can teach anybody to do that, but understanding when and when not to do that is critically important. That's what makes you a clinician and not a technician. And as such, these things are going to be really, really important to assess for your patients. So things that we're looking at here, especially about the way the patient thinks and they talk, is first of all, can they stay focused when you're talking with them? Now, understand, we all get distracted. When I'm tired, I have ADHD really, really bad. I'll be thinking about one thing over here, and then all of a sudden, now I'm thinking about something over here. That's not what I'm talking about. But when you're trying to have a conversation with a patient, can they carry on just a really, really simple, rational conversation with you, or are they all over the place? Can they maintain eye contact with you as you're talking with them? Or are they looking away and they're coming over here? That's something that's really, really important. Is their speech tangential? Basically, that's a going off on a tangent. Are we talking about one thing and then all of a sudden their conversation changes up to something that has nothing to do with what you're talking about? That deserves deeper inspection and evaluation. Is the patient oriented? Now, let me ask you a question. When I say, is the patient oriented, what does that mean? How would you determine, especially for my EMTs in here already, how would you determine if your patient is oriented?
Like if they know who they are, where they're at, where they're going.
That is critically different than being awake. It is very easy for your patients who have some type of a brain issue to be awake. Now, the question that you have to determine is, are they alert and oriented? And that's the quickest and the simplest way of the things that you just said that will help you to determine that they are both awake and oriented. I've heard EMS providers call in that the patient is awake, alert, but confused. That's impossible. It can't be. If you're alert, okay, and alert is the same thing as oriented. I know what's going on. Now, you can have different degrees of alertness, okay, but you can't say that your patient is alert, flat out statement, without qualifying what is going on in there. Does your patient ask the same question over and over and over? This is one of the things that we will see with any patient that has some type of brain trauma, whether it's caused by a stroke, whether it's caused by direct trauma, is that they will ask you the same question over and over and over. This requires great patience on your part. Generally, the way that it goes is, especially if you've got some type of patient that has either a concussion after like a football injury or a motor vehicle accident, it's kind of like, what happened? Well, you were in a car wreck. Am I going to be okay? We're going to take really good care of you. We're going to the hospital. Was anybody else hurt? No, you were just in the wreck by yourself. Oh, okay, thank you. 30 seconds later, it's like finding Nemo, you know. What happened? You were in a car wreck. Am I going to be okay? Well, we're going to take good care of you. Was anybody else hurt? No, you were only by yourself. And so this will continue until the brain begins to heal itself. Or in certain situations, that may be what the patient is left with in severe head injuries. But again, if the patient's asking you the same thing over and over and over again, it's going to be one of those things of now we got something major that's going on here. Travis, do you have a question?
Oh, yes, sir. So how would document the patients? ANO times 4, but say they're like dementia patients, they've got bouts of lucidity. So sometimes they're there and they're with it, and then they're talking about things that aren't there.
So one of the things you got to be really careful because we can jump into a routine. You can die if they're ANO times 4, but now they have a bit of an altered mental status or the lucidity is different. They're no longer alert. You can say they're awake and they respond appropriately to, they know who they are, they know where they are, but they're unable to tell you the time of the day or the year. The other thing I want to stress is be very, very, very careful if you're asking a patient what time it is if you're getting a call in the middle of the night. I wake up in the middle of the night and I have no idea what time it is either, okay? And so, again, that one may not be as valid for you to do. You can always ask them, what year is it? And that will be helpful for you as far as your assessment goes on your patient. And so your question is really good because the next thing that comes into play here is alert and oriented, okay? Now, basically what we're looking at here is ANO times 3 or ANO times 4, depending upon how you go. But alert and oriented means that ANO times 1 is their alert to their name. They can tell you what their name is. And again, you may need to confirm this with a family member or a bystander, and they know who they are. Okay? 2, they're alert to place. They recognize where they are. Again, give your patient a little bit of leeway here, especially if they're traveling and they call you in the middle of the night because they may not immediately know where they're at. If they're, let's say that somebody's traveling and they're staying in a hotel and you ask them, well, can you tell me where you're at? Well, okay, let me think a minute. Because part of that may be because they're just simply tired. But alert and oriented times 2 to person. Time, okay? Any of the ones that you see there are reasonable. And you can start from a macro level of saying the year and then work your way down if you wanted to fine tune that to make sure that they're alert. Okay, it's 2024. Well, can you tell me what time it is? Well, it's almost lunchtime. It's almost time to go eat. And then the last one is to the event. And this is one of the research, not the research finding, but this is one of our assessment things that we do as far as when we're getting our history on our patient. Can they tell you what happened? Do you remember what happened as to why you called for EMS? And so these are all important things to do. You need, in the cases of neurological emergencies, to assess these probably about every 5 to 15 minutes, depending upon the severity of your patient. Now, obviously, if your patient's unresponsive, they're not going to answer any of these. So you already know the answer to that. But you can go back, as we'll see in just a little bit, you can get a perspective on their degree of unresponsiveness by using what we call, I hesitate to use painful stimuli, but I prefer the word uncomfortable stimuli. And we'll talk more about that in just a minute. When we're looking at our patients, basically we use two things to help us to determine their level of alertness. One is called AVPU, AVPU. You can see it first right there on the slide. That's a mnemonic that stands for different levels of consciousness. A is alert. V is verbal. Patient is kind of like sleep, and when you call their name out, they wake up, okay? And they'll go back to sleep. P is painful, and this is the area. When we talk about painful stimuli, do not do harm to your patient, okay? I've seen paramedics and EMTs that will stick ammonia ampules up a patient's nose. That's a good way to lose your license because it can precipitate an asthma attack. Ammonia is caustic, so it can actually cause some damage to the mucous membranes of the nose, okay? But generally what we do is that we pinch the trapezius muscle, or we take the knuckle and we moderately rub against the sternum, okay? If you're leaving a mark, this is assault, not patient care. The other thing that you can do is that when you've got a patient that is not waking up when you call their name, take and gently touch their eyelashes, okay? If you get a little bit of a flutter, they're responding to that, okay? So that's that painful stimuli that you would report. And then U is unresponsive. The GCS is a Glasgow Coma Scale. I got to be honest with you, I'm not a big fan of GCS, but I'm going to teach it to you because you do need to know it. And we'll talk more about that, and we'll have some practice on GCS a little bit later on. When we're assessing our patients, and it talks in here about the 12 cranial nerves, back in the old days, all paramedics had to memorize all 12 cranial nerves. I don't do that anymore. I leave that for you to learn in your anatomy and physiology class. But what I am very interested in doing is helping you to learn to assess those particular areas. It's not as important for me to know that when I'm assessing cranial nerve 1, I'm assessing whether you're able to smell or not. What is important for me, especially in light of COVID, is if you tell me you got some respiratory issues and now you haven't been able to smell anything for 3 or 4 days, it's kind of like, ooh, that's important for me to know because that's an indicator of potentially having COVID. When you're assessing your patient, compare one side to the other, especially in your neurological emergencies. Remember, this side controls this side, and this side controls this side. That's called ipsilateral or contralateral control. Ipsilateral means left side controls the right, same way as contralateral, left side controls the right, and vice versa. So you want to compare those. One of the things that we'll teach you in here is called the Cincinnati Pre-Hospital Stroke Scale. And we do different things. There are 3 really simple tests that are very, very sensitive to helping you identify that your patient is having a potential stroke. And we are able to assess one side or the other. And then the last one there is gait. We generally don't assess gait in the pre-hospital arena because we don't want our patients walking and falling down. If you're working in the hospital, though, you may ask the patient, have you had any trouble walking? Well, yeah, I drag my left foot every now and then. That could be a nerve problem in the leg, or it could be a cerebral problem going on with a neurology. When we're looking at this, again, talking about AVPU, it's really, really quick. but it is also not really detailed, which we're okay with. At this point, what we're trying to determine is alert, or do they respond to verbal or painful stimuli? It's kind of a process that allows us to make a really quick determination of major changes, and then we can go back and we can look at the different areas to look at the uh, as far as whether they're oriented. So now, again, going back through this, when we're looking at A, remember that's awake. All right, that's awake. That does not necessarily mean that your patient is alert and oriented. And again, I want you to get into the habit of thinking alert and oriented basically means pretty much the same thing. V comes in here is that do they respond to verbal commands, okay? When you are asking your patient something, try, if they're unresponsive, their eyes are closed, try not to touch them first, because now we don't know if they're responding to your touch or if they're responding to your verbal command of, hey, open your eyes, or, you put a hand on the shoulder, the patient senses that somebody's there, and now they open up. P is, again, pain. It's basically just an uncomfortable situation. One of the things that I would encourage you to do, and I'm seeing less and less of this on a regular basis on ambulance, is stay away from ammonia ampules. They will get you into trouble. There's really no place for them anymore, just simply because there's a lot of bad things that can happen, some of which that I've already shared with you as far as determining whether your patient responds to that or not. We have other ways of determining with an uncomfortable type of sensation to determine whether or not our patient responds to pain or not. And then lastly, there's no response at all. And what we're looking at here would be flaccidity or flaccid, which basically means your patient's arms, there's no resistance whatsoever. Now, another thing that you do not want to do, okay? And this used to be an accepted procedure, but now it is no longer accepted in any way, shape, or form, is that a lot of medics, guilty until I learned better, would be, they would try to determine, is this patient really unresponsive or are they faking? Okay. In our world, we don't really care. Okay. If a patient is not responding to you, we document that. All right. If you feel like that they are faking, you document that as well. But you don't become punitive and punish someone because you feel like that they're faking. First of all, if you are indeed wrong and they're not faking, now you're guilty of malpractice at the lowest level and potentially criminality charges at the highest level. But one of the things that we used to do would be a patient that would be supine. And we would determine, we would think that they were faking. What we would do is we'd hold their arm up above their head, okay, and we would let it go. Most of the time, if they were faking unconsciousness, this is what would happen, okay? But if they were really unconscious, guess what's going to happen? They're going to hit themselves in the face. First of all, now the possibility of you inflicting additional trauma on an actual, genuine, legitimately unconscious patient has now just gone up. And you don't want to do that, okay? Especially if you've got a patient that has a potential for like maybe a bone disease, that just the fact of dropping and hitting their forehead may cause a fracture. If it hits the nose and now the nose starts bleeding, now you got some splaining to do, Lucy, if you go way back to I Love Lucy. So don't do that. Don't do that, all right? Y'all are much better than that. The Glasgow Coma Scale is one that is utilized, and whether or not you use an actual physical one or one on your phone, I don't care. So for your exams, I will give you a GCS table to utilize just simply because I would much rather you be right and accurate than just to simply memorize it. This is a part of a level of consciousness score that, again, as the name says, originated in Glasgow, Scotland. And basically, what it's used for is to determine a baseline and to see is our patient improving or are they regressing back as far as any type of process that's going on. If we see a change by 2 points or more, either positive or negative, that tells us that we've got a significant change that is going on. Okay? And the way that we do this is that we have 3 different things that we're going to evaluate. And we're going to evaluate them based on 1 up to a high of 5, depending upon what it is. Generally, what you're looking at here is the bottom of this bullet is really important, is that what we're looking for is the higher the score that we can get. If you've got a patient that has a 13 to 15 score, it may, keyword there is may indicate minor head trauma. This head trauma could be coming about as a result of lateral trauma, or it could be coming about as a result of some type of a stroke. A 9 to 12 indicates moderate trauma, and anything less than an 8 is very concerning. Now, one of the things, let me dispel this for you right now. One of the things we have a little mantra that used to be said in the past, that when we're talking about GCS, Glasgow Coma Scale, if you got a score of less than 8, you intubate. Wrong. We don't make up our determination of whether we're going to intubate a patient based off of a score. We look at the whole patient and we determine that. So again, you may hear some other people say, well, if their GCS is less than 8, you got to intubate them. No, that's not true. Not true at all. Now, when we're looking at this, basically what we're going to do is, first thing we're going to do is we're going to assess their eye opening. They get a 4 if they're able to open and close their eyes without being encouraged to do so by you. Okay? If you come up on the scene and their eyes are closed, they're asleep, maybe they have an altered mental status, but you call them out, you say, hey, sir, open your eyes up. And they open them up, maybe they'll stay open or they'll go back closed. Now we're going to give them a 3. Okay? If they open them up when you provide a painful stimuli, sternal rub, squeeze the trapezius muscle going on there, they get a 2. And if they don't open them up, no matter what you do, they get a 1. You record that number down. The next thing we're going to do is we're going to assess the verbal responses. Okay? Remember, eye opening is 1 to 4. Verbal responses are going to be 1 to 5. Their verbal response is, they carry on a conversation with you. They're doing just fine. They get a 5 on that. In 4, they're confused. Maybe they answer just a little bit slow. Maybe they have to think about where they are. Maybe they have to, if you ask them questions about, well, who's the president, or things along that line, they have to think about it for a little bit. So that processing time is a bit delayed. Now they're going to get a 4. If they are using inappropriate words not meaning curse words, swear words, or anything along like that, but if they're indeed swearing when they would normally not swear, or they're using random words, or if they're trying to talk to you in a sentence and the words in the sentence are all mixed up, they're going to get a 3. Now, here's the thing to keep in mind. Patients who have moderate to severe brain injury, and again, when I talk about brain injury, I'm talking about as a result of either direct trauma or caused by hypoxia or by a blockage or an aneurysm, will often use some of the most foul language known to mankind. Okay? That's an important finding, especially if the family is there and they say, we've never heard those words come out of grandma's mouth ever before, ever. That's an important finding, okay? Because what's happened is that part of their brain that inhibits, sometimes we think those words, but we have that filter that keeps us from saying them. That filter, that part of the brain has now been damaged. And so that whatever they're thinking is coming straight out. Incomprehensible words would get a 2. And basically incomprehensible words would be moaning, groaning. They're trying to say something, but you just don't understand what they're saying whatsoever. And then they get a 1 if they're not making any sound whatsoever. The last thing that we assess on here is their motor response. Okay, motor response is basically movement. Okay, so if you're assessing a patient and you say, hey, let me take your blood pressure, raise your arm up like this for me, and they follow it, you can give them a 6. They're following your commands and doing appropriately. If they are doing purposeful movement, okay, which basically means they answer, or they follow your commands, but it's slow or delayed. Much like we said a while ago, when you ask them a question, if it takes them a little bit of time to process it to answer the question, we're going to give them a lower number. If you ask them to move a body part or to do something, okay, one of the things that we ask patients to do is to hold out their arms when we're assessing for a stroke. If they look at you and they think about it for a second and then they hold them out, then we would give them a 5. They're not responding as quick. If they withdraw away from you when they're unresponsive and you cause pain, now you're going to give them a 4. 3 and 2 are critical findings for this patient. If your patient is unresponsive and basically they have their arms flexed up in towards the core of the body, that is called a decorticate movement. That means the cortex of the brain, that part of the brain that is behind the prefrontal cortex, is damaged. Not a good thing. If they have their arms extended out like this, okay, that's called decerebrate movement. That means the cerebellum or the cerebrum has been damaged. Don't worry about the names. I will not quiz you or test you on the names, decorticate or decerebrate, until we get into advanced trauma. You're going to get a 2 on that. That means that the degree of damage that has been done for this patient is much, much serious. Much more serious. And then lastly, you give them a 1. When you report this to the ER, when you report this to other people, you're going to report it in 2 ways. Number 1, we're going to give them an overall score, okay? But we're also going to break it down in your narrative, or when you're giving a verbal report. We're going to give them an I score, a verbal score, and a motor response score. That helps to tailor that score just a little bit better, okay? Now, I'm going to stop there. We've been going for about an hour. I'm going to record the rest of this. But do you have any questions on what we've covered so far.